Good evening, everybody, and welcome to our webinar tonight. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. I am coming to you tonight from Awabakal land. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. Our webinar tonight is the third session in our fertility series and is on Artificial Reproductive Technology 101. Our presenter is Dr. Matthew Holland. Don't forget that if you have any questions, please type them into the question box and we will endeavour to answer all of those as we're going. This webinar is being recorded and there will be a copy of it and of the slides put up in our education library. At the end of the webinar, a questionnaire will pop up, so if you could please all fill that in, we love to get your feedback. Okay, I think that's all you need to hear from me, so I will hand over to Dr. Holland. Thank you.
Thanks, Jenny. Thanks very much. Thanks, everyone, for coming tonight. My name's Matt Holland. I'm one of the Genea specialists at Newcastle. I also have a private obstetrics practice at Newcastle Private. I had a look at the names of people joining us tonight, and a lot of them are familiar. There's a slight IT glitch that I, at the moment, can't see all of your questions if you write them. So every now and then you might just lose the presentation view, just so I can go back and have a look just to see if you've got any questions. But ordinarily, a didactic type of teaching session is not normally my style. I much prefer numerous questions and a bit of interaction, which is hard by a webinar, but we'll see how we go. Although I have rooms at Newcastle Private and it takes a little bit of travelling backwards and forwards to Genea, I've got a particular interest in seeing patients throughout their fertility journey and having to go through IVF from time to time. But I especially really like following them through pregnancy and seeing them with a baby at the end of it. I think that's probably the highlight. I've been doing obstetrics for a little while now, but I still really get a kick seeing patients that have gone through a really tough time come out the other end with a happy baby. We'll go through a few things. I have put together a presentation which has a little bit of theoretical content, but I'm going to try, if I can, just to take you through a little bit of a journey of a patient that goes through IVF and exactly what's involved in an IVF cycle and with an egg collection and transfer. We'll include basically just some definitions and some stats surrounding fertility. We'll go through just causes of subfertility. Interestingly, general practitioners call me or chat to me a little bit from time to time, and they just want a little bit of guidance about what initial investigations are helpful, and I wouldn't mind just going through that a little bit because it actually cuts down time and effort from on a patient's behalf if we've ticked a few boxes before we see them. Patients always love to ask questions about what can enhance their natural fertility without needing to proceed to IVF, and I've got a few slides on that. Then we'll just go through what IVF is and what ICSI is, including the success rates at Genea and Newcastle, and a little bit about other assisted reproductive technology services through Genea and Newcastle. Just at the end of the presentation, I might just touch a little bit on pregnancy care after patients have been through IVF, because it doesn't necessarily then reflect a low-risk pregnancy, and there are a few additional things that we tend to like doing. So even as a senior registrar quite a few years ago, I'm not sure rightly or wrongly, didn't have much of a clue about exactly what was involved in an IVF cycle. So I'm going to base my talk tonight surrounding that. I hope people aren't sitting there saying, yes, I've heard this all before, but I hope that it's useful. Cool. So in terms of definitions, infertility has traditionally been described as the inability of couples to conceive a pregnancy after a year of unprotected intercourse. So that's been the traditional definition, but there's been a refined definition just looking at age, and the reason that that's there is just due to the awareness of the detrimental effect of age on fertility. So we tend to then say for patients that are less than 35 or 35 and less, that if they've been trying to conceive for 12 months, that's the traditional definition. But for patients that are 36 or older, waiting for 12 months before they're referred, that 6 months can have a little bit of a detrimental effect on fertility outcomes. So we advocate for then referral and initial investigation after 6 months for the patients that are in the slightly older age bracket. I'll go through a few more slides and I might just flick back to the other view that I've got, just so that I can see if anyone's got any questions, and shoot them through if you can. So that traditional definition of infertility comes from this cumulative pregnancy rates. Now I hope that you guys can see my cursor, the mouse on the screen. I think that this is slightly incorrect. I think that it overcalls the pregnancy rate slightly, but in the first month of trying, and this is for obviously age will affect these rates. I'm not sure, well, I have to be honest, I'm not sure, but this is probably reflective of someone that's less than 30 years old. So in the first month of trying, this graph would give a couple around about a 30% chance of falling pregnant. I usually quote 20 to 25%, which is why I think this graph overcalls it a little bit. After 2 months, this is reflective of over 50%, and I normally would suggest 40 to 50%. After 6 months, around about 60 to 70% of couples will have achieved a pregnancy. And then after 12 months, around about 90% of couples will have fallen pregnant, which then leaves, by the traditional definition of infertility, around about 10% of couples who can't fall pregnant after a year of trying to fall. Just let me pop back to the other view, just so I can see if anyone's flicked through a question yet, but no, they haven't. It's fine. I'll go back to the view that we were looking at. The boring bits, we'll just go through etiology of infertility. So we divide infertility into male factor, female factor, and unexplained. Now, historically, they've been 33% each. Across the last 5 years, female factor due to tubal disease has gone up slightly, particularly probably in Newcastle, where rates of STDs are slightly higher than the general population of Australia. But male factor infertility, which accounts for a third of all couples, number one cause is idiopathic. The second most common cause are chromosomal issues leading to either azoospermia or oligospermia. And interestingly, blokes that are using supplements and androgens causing a low sperm count accounts for the third cause in the male factor that we're seeing at the moment. So from the point of view of female factor subfertility, now if we go back a step, this might sound unusual, but a lot of the time couples sit there and there's a presumption that female factor represents about 70 or 80%. At least that's the feedback I get from patients, and they're pretty surprised to know that it's divided into thirds. But the general causes of female factor subfertility are firstly poor ovarian reserve. So not necessarily premature ovarian failure or menopause, but patients who, even at egg collection, when they're undertaking egg collection, get very poor egg quality and get very poor embryology. And I will chat about that a little bit in detail down the track, but still anti-Müllerian hormone, or AMH, is still the best test that we have to predict the ovarian reserve, given though that test still is relatively poor in terms of its accuracy. The second cause of female factor subfertility, as I mentioned before, is tubal disease. So blocked tubes can be caused from infection, endometriosis, scar tissue from previous operations, and idiopathic tubal obstruction is still commonly seen. Anovulation, particularly polycystic ovarian syndrome, is something that accounts for a large number of patients that we see through fertility clinics. And patients that have anovulation, around about 80% of them, we will be able to get them to ovulate using letrozole, which leaves around about 20% of patients who are resistant to oral ovulation induction, requiring progression onto IVF. And lastly, endometriosis, which is still a fairly not controversial, but the chance of it actually causing permanent, long-standing infertility is still fairly low. So sure, there is a reasonable number of patients that come through our fertility clinic that have endometriosis, but it's actually very rare for us to say endometriosis is the prime reason that you can't fall pregnant. That might be a contributing factor, but endometriosis, as I said, is one of the causes of tubal obstruction. So that leaves a third of patients who, after every investigation that we perform, sit there and I say to them, you obviously are still unable to fall pregnant, and we can't tell you what the reason for that is. And it's a pretty frustrating time for patients. And of course, the question then is why? And my answer to that is usually that there's obviously a problem, but our science at the moment is not good enough to tell you what that is. Now, in that, I then acknowledge that there are a group of fringe investigations in IVF that I don't necessarily subscribe to, and I haven't gone in depth into those investigations in my talk here. Things like natural killer cells, which might contribute to some of the unexplained infertility, but just keeping in mind that even though I will talk more about investigations, I haven't forgotten about the fringe stuff. I just haven't included it in tonight's talk. So we'll go through some investigations. So male investigations, fairly simple and straightforward. So a sperm analysis is performed, and the three things that we look at are sperm concentration, for which we like greater than 15 million per mil. Sperm motility, i.e. number of sperm swimming forwards, we like greater than 40%. And then sperm morphology. Now, sperm morphology is an interesting concept. Most of the time on a lot of pathology reports, the reference range for sperm morphology will say 0 to 100%. Now, at least at Janaea and Newcastle, we stick to a more traditional definition of what a normal sperm looks like. And we consider 3 to 4% sperm morphology to be completely normal. There are a lot of blokes that attend the clinic that for one reason or the other had their sperm analysis and their sperm morphology is 4%, and they look at a reference range from 0 to 100 and they think that that's woeful. And it's a bit of a relief for those blokes to know that actually the 4% is normal. So presuming that the sperm analysis is normal based upon those three criteria, there's not really any other male investigation that we can perform to see if male factor subfertility is the cause of their infertility. But if we see a sperm analysis which is poor, then we do proceed down the path of checking hormones. So we do an FSH, LH, and androgens just to make sure that they don't have testicular failure. And we also perform a karyotype to make sure that they have a normal karyotype and that there's not a genetic reason behind this suboptimal sperm analysis. I hope that you can see the graph there of sperm concentration. So this graph comes from, well, the story is that it comes from a prisoner who subjected himself to providing a sperm sample. It looks quite often, but the idea was just to demonstrate across a number of years that sperm concentration in males varied considerably. And that's why when we see a suboptimal sperm analysis, particularly if it is just sperm concentration that is lower than what we like, it's important then to repeat the sperm analysis a few months later. And that graph very nicely demonstrates that it's most likely that we'll see a rebound and then a normal sperm count down the track. Now that's a different story to if the sperm count is woefully low and the sperm motility is really, really low and morphology is something like 1%. In my practice, if I see the triple whammy, then I very rarely, I still do it, but I very rarely think that a subsequent sperm analysis is going to cure the problem. And just about universally, if males have an abnormality in those three things, then we can make the diagnosis of male factor subfertility. The downside of male factor subfertility, and I'll talk about this in a subsequent slide, is that we don't have a good treatment option for that apart from IVF using sperm microinjection. Just pop back again just to make sure that there's no questions. Sorry for having to do this time after time. No, not one question. That's fine. Sorry for my monotone voice as well. Right. Female investigations. So these investigations, I hope, when I mentioned earlier that it's nice for patients to come along with some initial investigations, this screen probably reflects something that's very nice to receive with a referral. So we always perform an FSH, LH estrogen, and just to confirm that ovulation has definitely taken place, we perform day 21 progesterone level. I've highlighted TSH and AMH in red because I have a separate slide for each of those. I tend to perform a prolactin, a karyotype, and a free androgen index. So a pelvic ultrasound is helpful, particularly if we're considering that polycystic ovarian syndrome is the cause of the infertility. I tend to perform an antenatal screen like rubella immunity and chickenpox immunity just for completeness, and it cuts down my workload when hopefully I'll see them when they're pregnant in the short term. And carrier screening has become significantly more popular in the last little while due to the fact that the triple screen is now Medicare funded. So just about every patient of mine now that I see for either pre-pregnancy planning or for infertility takes up at least the basic triple carrier screening. But as everyone might be aware, there are more extensive carrier screenings, but they come at a significantly higher price. I mentioned that I've got two slides, one on AMH and one on TSH. So anti-Müllerian hormone, this is Janae's slide, which is reference ranges for anti-Müllerian hormone for age. Now, probably by definition, the group of patients that we're seeing for infertility tend to have a slightly lower AMH. The exception to that is patients that have polycystic ovarian syndrome that have a significantly higher AMH. Now, this graph that you're looking at is perfectly valid It is accurate, however, it gives patients panic every time that they look at it, because just about universally their AMH is somewhere here, and they think that that then reflects the fact that they're doomed and they're not going to fall pregnant. Now, I take a slightly more pragmatic approach at just about any age, and and that pragmatic approach is that if the AMH is less than 5, then I would say to patients that that's something to look at and hold some concern, and then normally prompts those patients to proceed on to the next step in their fertility treatment sooner than what they otherwise would. And then I use an AMH of less than 1 as very poor. And so that, I think that helps even for patients that have an AMH of something like 9 or 10, that you would look here and think, oh, that's in the realms of diminishing ovarian reserve. I actually don't think, and I don't have data, but I don't think that it reflects woeful fertility outcomes. And so the purpose of me using that less than 5 and less than 1 pragmatic approach tends to give patients a little bit more hope than looking at this graph, which tends to have them in the miseries every single time that they look at it. The second slide, I'll just have a look at time because I don't want to run over time at all. My aim was to have it wrapped up well and truly within an hour for you guys. The second slide I put just in terms of subclinical hypothyroidism, and the reason I've put it is because no fertility specialist can agree on exactly what the right thing to do is in terms of TSH that's in a grey zone. So there has been good data, which is observational, that subclinical hypothyroidism has adverse effects on pregnancy in terms of a higher chance of preterm labour and preeclampsia. And there's also been concern from observational data about cognitive impairment for babies born to mothers that have subclinical hypothyroidism. Everyone agrees that if we see it, and by subclinical hypothyroidism, I mean an abnormal TSH with a normal T4. For TSH that is over 4, everyone agrees that they would treat with thyroid replacement with thyroxine. With a TSH between 2.6 and 4, so this is straight from Up to Date, and this is a bunch of authors that have written this chapter in Up to Date that even can't agree between themselves, and they acknowledge that one of the authors does one thing and one of the authors does something completely different. What I have put up on the screen is my practice. I completely acknowledge that the next fertility doctor might look at that and say, no, I do something different, but this is what I do. So if the TSH is between 2.6 and 4, then I don't necessarily use thyroxine straight up. I would then perform antithyroid antibody concentrations, and if they're positive, then I would use thyroxine. And for TSH of less than 2.6, I would advocate for not performing antithyroid antibody concentration at all, because with a TSH of less than 2.6, even if antithyroid antibody concentration were positive, then in my practice, I wouldn't treat with thyroxine. The basis of that is it's not that I'm being restrictive on treatment. It is the fact that all of the data then, large meta-analysis has actually demonstrated the fact that there's no significant beneficial effect of treatment. And so there's something about the underlying disease condition that is unchangeable that causes the adverse pregnancy outcomes, which is not remedied by using thyroxine. So I know that I've contradicted myself slightly there, but the slide that you're seeing is what I tend to do in my own practice. As I mentioned, patients always, quite rightly, love to ask what treatments I can offer them to improve the chance of them conceiving naturally without having to proceed down the path of IVF. I mentioned before that for male factor subfertility, there's no strong data towards improving live births with any treatment. And when I say any treatment, I include things like ceasing smoking, reducing alcohol intake, reducing BMI, and specifically Metavet. So Metavet does have some data towards improving sperm DNA damage, but the manufacturers of Metavet, to my knowledge, I could be corrected, have never demonstrated an improvement in live births from natural conception with its use. Obviously, males that are using androgens, which has then led to an abnormal sperm analysis, is remedied by ceasing androgens. A large proportion of those blokes believe that they can have HCG whilst continuing, and that will solve the problem. But at least in my practice, I counsel those patients towards the fact that I think that the best treatment option is to cease what's causing the harm. And then it usually takes at least 3 to 4 months for spermatogenesis to recover and for a sperm analysis to be normal. I put research into scrotal cooling. So the University of Newcastle, so Dr. Mark Baker at the moment, is embarking on a research project with the primary outcome being live birth rate for males, where it's thought that male factor infertility is the cause of the infertility. And the research is looking at scrotal cooling. Now, I won't do charades too much, but they have a device which blokes wear for 8 hours a day for a month or so. And the hypothesis is that scrotal cooling will lead to an increased live birth rate, both in the natural world and in the IVF clinic. Now, that's on the basis of historical data supporting varicocele repair, or having an indication that varicocele repair has a slightly higher chance of live birth rate. So they're embarking on that shortly. They're going to be recruiting for that hopefully in the next few months. So that'll be interesting to watch. Female treatments to improve natural conception, we have more evidence for. So there is clear evidence, and the graph over on the right-hand side demonstrates that BMI is an independent predictor of fertility outcomes, both in the natural world and in the IVF clinic. So that was particularly demonstrated in some studies that looked at women who were infertile secondary to polycystic ovarian syndrome. And the authors of that trial included patients who had a BMI over 25, and they embarked on weight loss journey for 6 months. Interestingly, in that study, the average weight loss across the treatment group was only 5%, and resolution of ovulation in that study was over 60%. Now, the majority of patients that I then present that study to actually take it on, and I think that at least from a pregnancy point of view as well, that if they can fall pregnant naturally with weight reduction and resumption of ovulation, that probably sets them up in a better place for a lower risk pregnancy than if they utilize other treatments. For patients who try BMI reduction and it does not work, then ovulation induction using letrozole is the next step that I utilize in my practice. It's probably worthwhile just touching on there that that historically we added, I've got a mental blank. Anyway, we now solely use letrozole. I usually start off on a dose of 2.5 milligrams for 5 days. Some people use day 4 to 9. That's what I normally do. And ovulation induction using letrozole has a success rate in terms of getting them to ovulate, usually of about 70 to 80%. I always talk about timing of intercourse to patients, and I'll got a subsequent slide on that. But importantly, HSG really is one of the prime treatment options that we can utilize for patients that has been demonstrated to increase the chance of them falling pregnant naturally. And I've got a slide on that too. So timing of intercourse, it's quite common for patients to wonder if they're having sex at the right time. This graph demonstrates that the chance of falling pregnant in comparison to ovulation. So ovulation is day 0 in this graph, If patients have intercourse the day before they ovulate, then that represents the highest chance of them falling pregnant. If they're having intercourse 2 days prior to ovulation, then that's their second best bet. The day of ovulation is still reasonable, and the day after ovulation is 0. So I normally counsel, and there is good data to support the fact that if patients are having intercourse every 2 days leading up to ovulation, they're not going to miss the mark. Understandably, it's quite common for patients after they've been trying to fall pregnant for so long to say, look, that's not fun anymore. And they're obviously quite rightly very focused on having intercourse when it's important. But I hope that graph is a little bit helpful in understanding the right time. So hysterosalpingogram, it's used as an investigation and a treatment. It has been demonstrated in numerous meta-analyses to increase natural pregnancy rates. It can either be done awake by putting a catheter through the cervix, injecting dye, and then taking an X-ray, or if we're doing a laparoscopy because there is a suspicion that endometriosis is present, we can do it at the same time under general anaesthetic. The New England Journal of Medicine in 2017 demonstrated really well. They included over 1,000 patients who were infertile, and by that definition, they said patients who've been having regular intercourse and unable to fall pregnant after a year. Then they flushed their tubes, and after 6 months after follow-up, 28% of the patients had a live birth that used water-based solution to flush their tubes, and 38% live birth rate if they used an oil-based solution to flush their tubes. This paper was primarily looking at water-based versus oil-based, but it still demonstrated a significantly higher chance of pregnancy even with the water-based in comparison to doing nothing. And the doing nothing, still the 6 months after they had been trying for a year, I usually then quote patients at 2 to 3% chance per month, which comes up to about 18% chance if they didn't have their tubes flushed. So there was a significantly higher chance of them falling pregnant. I may have muddled my words, and I hope it wasn't too confusing. The next bit, after all the boring theory bit, is I just want to take you through what's involved in an IVF cycle and ICSI and a little bit about what a patient will go through during that process. I'll just pop back to the other screen just in the hope that someone's got a message for me. Not one. It must have been fairly suboptimal.
There is a question there, actually, Matt. Is it worth starting metformin on patients with PCOS to help with ovulation?
Okay, I'll go back to my slide. And I brushed over it earlier on, and that was my mental blank because I was trying not to look too silly, and I just forgot the name of metformin. So historically, we used metformin in combination with Clomid back before 2010, with the thought there was a small study somewhere around 2008 that suggested that adding metformin increased the chance of patients ovulating. Now, subsequent to that, there was another couple of studies that demonstrated in actual fact that there was no significant difference. So that led the fertility world to cease using metformin in combination with letrozole if the goal is to induce ovulation. Interestingly as well, there is still a suggestion that using metformin alone increases the chance of ovulation. In all of the data that's there, I can't find any that suggests that metformin has a role in inducing ovulation. I presume what it does do is if the dose is high enough, there are a subset of patients that feel nauseated and increase intake and they decrease their BMI, leading to a slightly higher ovulation rate. But yeah, thanks for the question. The short answer is no. I don't know of any fertility doctor now that includes using it as part of their ovulation induction regime with letrozole. I hope that answers that question. So IVF and ICSI. The decision to move on to IVF for patients is a fairly individual decision. There are some couples that turn up obviously with a problem and they say, I know I've got blocked tubes, I've had a test, or I know I'm not ovulating and I've been trying to use letrozole for 6 months and it hasn't worked, and say, I actually now want the thing that's going to give me the highest chance of falling pregnant in the shortest time period. And patients come up with their own timing to do that rather than us push them into it. It becomes plainly obvious to the majority of them. The decision to move on to IVF then involves us registering the patient with Genea. Genea then contact the patient across the next week or two, and the request is then to make an initial appointment with the nurses at Genea. That initial appointment is quite lengthy because it includes all of the education surrounding what an IVF cycle looks like, what's involved, what drugs are used, and how to inject them. And then they're logged on for an IVF cycle and they start their medication. So step one in this process is stimulating the ovaries. Step two is performing an egg collection under, I'll explain, but we use midazolam and fentanyl at Genea Newcastle. Step number three is fertilizing the eggs, and we either do that with conventional IVF, that is putting sperm in the same dish as the egg and letting fertilize occur naturally, or if male factor subfertility is the cause of the infertility, then we use intracytoplasmic sperm injection, which I have a really nice, I hope it works, I've got a really nice video that I still like looking at every time I look at it. We then culture embryos in an incubator for 5 days, and we transfer a day 5 blastocyst back in the clinic. We then continue luteal support with progesterone and do a pregnancy test 8 days later. That's a bit of an overview to the slides that are just going to come up now. So the top slide here, we have 2 different types of IVF cycles. The first cycle is a long cycle. The second cycle is a short cycle. Historically, we had used long cycles, and what we do there is patients get a period. We then start them off on a Cineral nasal spray. They stop the pill and get another period, and then we use FSH injections. When the ovaries, when we're happy with the size of the follicles, and I'll explain that in a minute, we then give a trigger injection to cause patients to ovulate. Now, obviously, we don't want the ovary to give the eggs up, and we want to get in and do an egg collection before that happens. So we time our egg collections to 36 hours, just about to the minute, after patients have the HCG trigger injection. The purpose of the HCG trigger injection, you might ask, is that if we don't want the ovary to give the egg up, then why actually give it? HCG does 2 things. The first is that over here on the right, I hope that you can see, this is a picture of an ovary that's been stimulated with FSH. These are follicles, and the follicles just have follicular fluid in them. The criteria that we use to then give a trigger and proceed to do an egg collection is we like 2 follicles to be at least 19 millimeters, and we like the estrogen in the blood to reflect usually the estrogen we like is about 1,000 per mature follicle. So estrogen somewhere between 2,000 and 7,000 are fairly common. Now, we give the HCG trigger in an attempt the egg sticks to the side of the follicle, so the HCG helps the egg come off the side of the follicle where it's attached and just float around freely in the follicular fluid. The other purpose of the HCG trigger injection is that it aids in maturation, or the final steps in mitosis 2 of egg development. So it helps the final step of the actual egg development, aiding the embryology and fertilization. So a long cycle is something that we've historically done, but for numerous reasons, including patient request, a short cycle is now significantly more popular, probably as is not as onerous for patients. It's definitely shorter, there's less steps, and the outcomes are very comparable. So with a short cycle, and this is now what we tend to do, is patients either get a period naturally, or they can take the combined pill and then stop it and get a period. We start daily FSH injections from day 2 of their cycle. Then on day 5 of their cycle, we obviously don't want the hypothalamus to pump out FSH and LH and cause ovulation. So we start a GnRH antagonist to stop the hypothalamus producing LH, and we don't, in an attempt to ensure that it doesn't then lead to ovulation. We then start tracking the size of the follicles, and most patients will be up for 2, sometimes 3 scans and blood tests at the same time before we say, yes, the follicles are the right size. We'll give the trigger injection and we'll proceed to an egg collection 36 hours later. I'll show you some pictures of our procedure room that we perform egg collections in, explain a little bit about what we do in just a moment. It's important to know, it's probably important to know at this step that there is no software and there's no certainty that the drug dose that we are giving patients definitely leads to a reliable ovarian response. Now, we can make patients sick with ovarian hyperstimulation syndrome, and so in an effort not to do that, I think the majority of fertility specialists start off on a slightly lower FSH dose. But I always counsel patients that if their FSH dose is not then leading to adequate ovarian stimulation, then my preference is to cancel the cycle and to start off over again at a higher dose. Now, patients don't pay the large fee that they pay for IVF until they actually have an egg collection. So as frustrating as it is for patients, the majority are completely aware that we're doing it in their best interests, in an attempt to make sure that we get the ovary stimulated to an ideal point. The cancellation rate at Janae and Newcastle is around about 20%. And we actually, as frustrating as it is for patients, it means that our rates of ovarian hyperstimulation syndrome are extraordinarily low. And still, in the end, our live birth rates are extraordinarily high. I hope that those graphs explain short and long cycle. So egg collection. So 36 hours after the trigger injection, patients get admitted through day stay at Lingard Hospital for an egg collection. So this is the bed that we use. We use a transvaginal ultrasound probe with a needle guide on it. So we do all of our egg collections under ultrasound guidance. We do one ovary, then the other. We usually use 100 micrograms of fentanyl and 2 milligrams of midazolam, although we can titrate that if the patient's too uncomfortable. And we also use some local anesthetic. So we will introduce a transvaginal ultrasound probe, put local anesthetic around the outside of the ovary, then introduce the needle with negative pressure to suck out each follicle. I don't have a video of that, but we pretty much just go from one follicle to the other, draining every follicle that's safe to do so. Then we repeat on the other side. Now, the liquid that we draw out ends up in warmed test tubes, which end up being just on the patient's abdomen. And when the test tube fills up, the nurse will then hand it off to the embryologist that's over here at the crib, looking down a microscope, counting the number of eggs that we're able to retrieve. They let us know as we're emptying the follicles how many eggs they're up to, but they're always a little bit behind because there's usually a couple of test tubes over to the side in the crib that have liquid in it that they've yet to count. The whole procedure, from the time that patients come in to the time that they leave, tends to be no more than half an hour. A whole lot of that time is doing ID checks, putting a cannula in, giving Midaz and fentanyl and setting them up. The actual egg retrieval process is usually a maximum of 10 minutes. Now, so we use midazolam and fentanyl. There are a number of IVF clinics that have tended historically to use general anaesthetic. Patients can still request a general anaesthetic at Janaea and Newcastle if they would like to. However, there are the number of patients who have had both general at an alternate clinic and Midaz and fentanyl at Janaea and Newcastle. I can't remember the last patient who said that actually the Midaz and fentanyl was woeful and they must have a general anaesthetic if they are to have an egg collection in the future. And the other advantage is that their partner can be with them, which is a nice consequence of a slightly alternate method of anaesthetic. I hope so. This is ICSI. I hope that this video is playing for you guys. So this is on the day of egg collection. The embryologist, the bloke will produce a sample. That's the embryologist breaking the tail of a sperm, and the reason it does that is, number one, it immobilizes the sperm, but it also apparently sets off some reaction within the sperm as well, which aims to help fertilization. The next thing that the embryologist will do just now is suck that sperm up into the pipette, and then they will get the egg, which is here. The egg looks different at the time of egg collection. You can't really make out whether it's mature or not, but in the afternoon the embryologist strip off all of the cells on the outside to reveal an egg that looks exactly like this. If they're doing ICSI or sperm microinjection, as I said, it's usually for male factor infertility. And in a minute, the embryologist will hold the egg under a very, very small amount of negative pressure, just to stop it rotating around. And you'll see that just now. And then the next thing that the embryologist will do will be to inject the sperm into the center of that egg, which is pretty cool. Whilst you're looking at that, I'll just double check our time. We're good.
We have got a couple of questions that have come through.
Sure.
As GPs, what can we start initially for our patients trying to conceive?
What can we start in terms of, was
Yeah.
that in terms of investigation or was that in terms of treatment?
I
Or
think
does it,
in terms of treatment, because then they've got question mark metformin.
yeah, so sure, there are a substantial number of patients I see. So that was, before I answer that, that was the embryologist injecting the sperm into that egg, and then she or he will flick that off to the side and do the next one, and then they will check for fertilization the next day. And seeing those two poles there is evidence of fertilization the day after either IVF or sperm microinjection. Pretty cool. I'll go on to the next slide and I'll show this video in a minute, but I'll attempt to answer that question before I do. Gee, general practitioners more than happy if they've initiated utilising metformin. I tend to not stop it if they've come. However, I hold a belief that metformin, the indication in fertility, I would suggest is insulin resistance more than utilising metformin for ovulation induction. My preference would be that if a patient needs ovulation induction, that we undertake that with letrozole as the sole agent, on the basis that all of the data suggests that the outcomes are as good or actually slightly even better than if we're using metformin in combination. I hope that answers that question.
There is one more. Letrozole can only be prescribed by specialists, but can GPs continue prescribing?
As far as I know, they can. I suppose I've fallen into this trap. I'm not sure that I've got any less of a chance of falling into a trap than the next person. I don't think that letrozole is a drug that's particularly dangerous. Its main risk, and I think the thing that I normally counsel patients towards, is an 8% chance of multiple pregnancy using letrozole. But at least in my practice, I've had patients who have fallen pregnant on letrozole and had a baby, and then their GP has prescribed them letrozole for their second baby, and that's been all fine. The only little caution I would have is if the anovulation is secondary to polycystic ovarian syndrome and the patient has then lost a lot of weight, that the letrozole dose might need to be altered a little bit. So if they needed to increase the dose to 2 tablets a day rather than 1 to ovulate in their first pregnancy, and then they lose weight and then use 5 milligrams to try and fall pregnant in their second pregnancy, the chance of multiple pregnancy is significantly higher. And I have fallen into that trap myself and ended up with a patient that had triplets that started off of her own accord with some letrozole that she had left over, and she had lost a considerable amount of weight in between. Was there another question there, or was that were there just those two?
Just those two.
Okay. So once fertilization has occurred, the incubators that we use are over here on the right, the Jerrys. The scientists can see on the screen what the embryo is up to, rather than historically needing to take the embryo out and look at it under a microscope. So the Jerry that Janae actually produced has been demonstrated to have a significantly higher live birth rate than historical incubators that were used up until around about 5 or so years ago. The video I'm just about to show you is an embryo which goes from fertilization through to a day 5 hatching blastocyst. So you will see in it fertilization, then the cells split into 2, then 4, and then eventually you will see cells that line the outside of the embryo and the cells that are a clump of cells on the inside, which then demonstrate the blastocyst. And Janae now have a policy of only transferring 1 day 5 blastocyst. It's a pretty cool video. I hope it plays for you. So that's from fertilization, then splitting into 2 cells, then splitting into 4. And usually cell stage takes us up to about day 3. Then eventually you'll see some cells on the outside start to form around about now. So see these cells out here, then a clump of cells on the inside. This is where this embryo starts to hatch, and this will be around about day 6. I suspect that this embryo is going to be biopsied because most of the time they're frozen before they hatch right out of their zona. It's pretty cool. I'm going to play it once more because I still like looking at it every time, even though I seem to see it on a daily basis. It still blows my mind being able to collect eggs, put sperm with it, culture an embryo to day 5, and then end up delivering a baby at 8.5 months later. It's cool. I'll go on to the next slide. I put this slide here, as I said, perform day 5 single embryo blastocyst transfer, there is a natural frustration for patients throughout the cycle of IVF. It engulfs their life. It's quite rightly, it's everything that they do for a month or so. It is really difficult for patients between the time of transfer and pregnancy because there's really nothing that they can do to improve the chance of it sticking. But importantly, I find it's very important to explain to patients that there is a natural degradation of numbers across the cycle of IVF. That is, I'm making numbers up here. We can collect 10 eggs. Our average is 8. Let's say we collect 8. 7 are mature. 5 fertilise. 3 make it to day 3. And usually the majority of patients end up with 1 day 5 embryo. There are some patients that end up with more than 1 day 5 embryo, but they're actually the minority. So just setting the barometer at the right spot. And it's still extraordinarily upsetting when patients come in and they look up at the screen and they still say, is that the only one? And that's normal, but there's still a natural sadness about that. But I still try and set the barometer at the right spot just so I don't think that what they're going through is abnormal. If there is more than 1 day 5 blastocysts, then they're obviously frozen. But the goal, and we always mention to the patients that the goal is to have 1 good quality day 5 blastocyst per transfer. We perform a transfer 5 days, as I said, on day 5. It's in a slightly different room. We do it under ultrasound guidance. So we look at the cervix like a pap smear. We pass a catheter through, which has an outer catheter and an inner catheter that holds the embryo. I don't have a video of that. And then once we know that we're in exactly the right spot in the endometrium, the scientists will deploy the embryo. We, for whatever reason, probably because I was taught this way, spin the catheter around a little bit in an effort to make sure that it doesn't stick onto the end of the catheter. We remove the catheter and the embryologist will also always look at it just to make sure that it's definitely being deployed from the catheter. That process of transfer takes 5 minutes and is 90% of the time is very straightforward. As I mentioned, any embryos which we will freeze and patients consent before they undertake IVF for the number of years that they consent, that they are willing to have the embryos frozen. There is obviously a monthly charge, which I don't have in my head, for keeping frozen embryos stored at any IVF clinic. Importantly, I think it's worthwhile going through the success rates. So this is actually the most up-to-date data that our clinic has. Every clinic now will provide their data to ANZARD, which is the governing body looking after IVF statistics. ANZARD then takes some time to validate the numbers that we present them, and they eventually write back and say, yes, the numbers that you've submitted have been validated and are now for public display. And there is a website now called Your IVF Success that in slightly different format will demonstrate the success rates of every IVF clinic in the country. I am really happy that Janae in Newcastle has, for the past, at least for the past 5 years, sat at either 1, 2 or 3 in terms of success rates for Australia. There's always rivalry, it seems, between Janae in Newcastle and Janae Liverpool, which pipped us at the post for the first time last year, but we were still happy to be right up there in the table. So can we concentrate on this top graph, which is the majority of patients, because the minority of patients will have a frozen embryo transfer. That's the bottom graph. So for fresh embryo transfers, this graph has divided this into years. So for the less than 30-year age group, the The light line is clinical pregnancy. So clinical pregnancy is seeing a heartbeat at 7 weeks. Obviously, the pregnancy rate is higher than that. And from the back of my mind, the pregnancy rates for a cycle of IVF in the less than 30-year age group was somewhere around 70 or 71%. Obviously, then after miscarriage, seeing a heartbeat at 7 weeks was 63%. And the yellow line is live birth rate. So it was a 54% live birth rate in this year, which this year, it seems like a long time ago, but this most current, most up-to-date data that ANZARD have validated, this was for the year 2021. For the next group, the 30 to 34, a 49% clinical pregnancy rate and a 44% live birth rate. Obviously, it's slightly lower for the next age group. And for the 40 plus, the only little hesitation I have about saying 40 plus is that, yes, there was a 20% live birth rate, but there was a steep fall off, just about resembling a cliff, for success rates when 42 came about. And we usually then quote the chance of a 43-year-old having a live birth through IVF as somewhere around 1 to 2%. So I'm just probably cautioning that if patients look at that data that are 42 years old, that they're being misguided a little bit if they think that their live birth rate is 19%. Now, obviously, frozen embryos, some of these numbers, maybe not here, but historically some of these numbers were slightly higher for frozen embryo transfer. So in the 30 to 34 and 35 to 39 and over 40 in this graph, all demonstrated slightly higher live birth rates. Now, the basis of that is if embryology was so good, if their embryos were so good that actually got some frozen, the chance of them falling pregnant with a frozen embryo transfer by definition then was significantly higher, which is why it looks that way. Keeping in mind that the number in this group were quite low, the number in the fresh embryo transfer group was obviously just about everyone. This is pretty much the last slide. I hope I haven't kept you for too long. That's been about an hour. Didn't want to hold you guys up too long, but because my special interest is caring for patients throughout their pregnancy after they've undertaken IVF, it's a different can't articulate my words properly, but it is definitely a different care in terms of managing patients' anxiety, especially in early pregnancy. For patients who have been through IVF and have undertaken a whole lot of mental exhaustion in the first place, I feel like the necessity to provide additional scans and additional reassurance is just about essential. Now, there is some good data. This was Nature 2016, which summarised it pretty well. And for reasons that are not completely understood, it is very well reported that for patients who have undertaken IVF and ICSI, that they had a significantly higher pregnancy complication just about for every single pregnancy risk. But I've documented some here from that journal in 2016. So gestational diabetes was double, preeclampsia was double, placental abruption, there was a 4 times higher chance of an abruption during pregnancy for patients that had been infertile. Growth restriction was double. The chance of stillbirth is unfortunately 3 times higher in the subgroup of patients who have had IVF, and so is ruptured membranes. It is for those reasons that I would not say that pregnancy care after IVF is extraordinarily low risk. I also wouldn't say that it's high risk, but I would say that additional monitoring, I look at growth for every patient in the 3rd trimester, looking at abdominal circumference. and Lycor and Dopplers at every appointment, particularly for patients who I'm aware that have been through IVF and by definition have a significantly higher chance of having a pregnancy complication. I think that just about, I didn't want to end off on a negative note, but that just about concludes my series of slides. I might go back to some questions, but I hope that that provided a bit of insight into what patients go through when they're undertaking IVF, the challenges that they have, and just a little bit about the care that I like to provide them when they fall pregnant. Let's see what questions are there. I can see some. I'm just reading the questions, sorry, through my multifocals, which is why I'm looking a little bit like that. Yeah, there's obviously still a few questions surrounding metformin. I know I've sounded fairly negative. I think I'm just basing the use of metformin on the data that I'm aware of, and in my practice, apart for patients who I'm using it because of insulin resistance, in my practice I don't ever prescribe metformin when I'm undertaking ovulation induction. My my preference would be that if someone is not ovulating, then that's probably the point that a referral to come and see me is indicated, and I think that patients would then have a good outcome. Yeah, so there is one question. What is the cesarean section rates above amongst IVF patients? That's a difficult question to answer because I think that it's dependent on practitioner. Now, I suppose I can just talk in terms of my own practice. My cesarean section rate, so the public hospital cesarean section rate tends to sit, to my knowledge, somewhere between 35 and 40%. My cesarean section rate has been slightly above 40%, which then reflects the fact that I'm also a private obstetrician delivering patients who their main purpose of seeking private obstetric care is to have a cesarean section. My cesarean section rate's slightly less than the hospital average. I wouldn't say I've never counselled patients towards the thought that cesarean section is indicated just if someone has had IVF. But to be 100% honest, I do counsel patients towards the option of having earlier induction of labour, somewhere between 39 and 40 weeks, rather than 40 or 41, for the purpose of minimising complications in labour secondary to having a history of IVF. And if you are a believer of the ARRIVE trial, that has demonstrated that undertaking induction of labour at 39 to 40 weeks has a significantly lower chance of emergency caesarean section rates than if that patient waited until 41 weeks. I know I haven't answered that question with exact numbers, but I would not say that the rates of caesarean section amongst those patients are significantly higher. Yes, they might be a little bit higher upon request, but not significantly higher. There was a question, I'm struggling to see the second half of the question. Jenny, can you see the question about implanting multiple embryos? I just can't quite read all of it. You might be on mute.
Yes, I can. A candid question about implanting multiple embryos and sex selection, as it does come up, and these are obviously emotive topics and global ones.
Yeah, it's a good question. So Genea as a body have their stance is that they will only implant a single day 5 embryo. Now, the basis of that is that the outcomes of patients, if we put 2 embryos back and cause twins, the pregnancy outcomes for those patients very, very poor. Of course, there are a large number of patients that do very well with twin pregnancies, but if you were to probably describe or come up with the highest risk pregnancy, twin or triplet pregnancy is probably it. And then for a little while, Genea held to the single embryo transfer while other companies were still putting back more than 1 embryo. But then there was some evidence towards the thought that putting 2 back actually has a lower chance of a live birth. And that is that if one of the twins miscarries early, it tends to then take the other one with it. And so that data, which came out in something similar to 2016, just confirmed Genea's stance that they would only ever put a single embryo back. Now, sex selection, so we can't sex select in Australia. That was reviewed in around about 2018, and at that point it was determined that sex selection will continue to not be legal in Australia. We occasionally are allowed to do it for genetic conditions, obviously affecting males or females, but for patients who come requesting sex selection, the only viable way to do that is to go abroad and have IVF and have genetic testing of the embryos and only put back the gender that they want. As much as some people believe that it should be available in Australia, it's not. Cool. I think that's around about all of the questions. Thanks very much, everyone,
Yes, it
for
is.
joining.
Thank you so much. That was a very interesting talk. And thank you, everybody who's attended tonight. Don't forget to fill in the evaluation. And I'll catch you all next time. We have one more webinar left in this series on fertility. Thanks so much, Dr. Holland. See you all
No worries.
next
Thanks,
time.
everyone. Have a good night. Catch up.